دكتور عمرو عواد هيكلمنا اونلاين ان شاء الله. هو كان مفروض هيكلمنا عن
Good
الابروتش
evening, my
تو
dear
تشايلد
professors and colleague.
with
I am عمرو
lymphadenopathy.
Ahmed, lecturer of pediatric
خلاص هو ابتدى
hematology,
فحسن.
Faculty of Medicine, South Canary University. First of all, I would like to express my great honor and pleasure to have this kind invitation from Professor Dr. Helen Nedi to participate in the 6th International Pediatric Conference of Society of Respiratory Research and Pediatric Nutrition. Actually, this invitation gives me like a window to meet this eminent group of professors and colleagues while being outside Egypt. Today, I'll try to, in brief, spot the light on a case that we, of course, had and will encounter in everyday today practice in our clinics. Approach to a child with lymphadenopathy. Pediatric lymphadenopathy is a challenging medical situation for the patient, the parents, and the caregivers, and the treating physician also. According to article published about 3 years back in Pediatrics, cervical lymphadenopathy affects about as many as 90% of children aged 4 to 8 years. Although the majority of these masses will be benign, the fear of malignancy is ever present. While assessing a case of a pediatric patient with lymphadenopathy, the only way to reach a final conclusive decision is at the end of the day is to be systematic and follow a stepwise approach. Actually, I believe that this is the only way to reach a final conclusion, a final wise conclusion about every case is to be systematic and to follow a stepwise approach. So please, in order, go through history, examination, and at the end, investigations. While taking history for a patient with lymphadenopathy, for a child with lymphadenopathy, to be more precise, you should focus on the duration of lymphadenopathy. Acute infective adenitis is usually less than 2 weeks in duration, while lymph nodes enlargement that persists for more than 6 weeks is called chronic or persistent lymphadenopathy, chronic lymphadenopathy that may carry a broad range of differential diagnosis other than being acute infective adenitis. Fever, presence of fever may indicate acute infective issue, but also fever present in the non-benign conditions causing lymphadenopathy. You should ask about the history of infection. If you are dealing with jugulogastric or cervical lymph nodes, ask about history of earache, recent upper respiratory tract infection, sore throat, tooth pain, and whatsoever. You should ask about symptoms of infection in the area drained by the enlarged lymph nodes. If you are dealing with a case of occipital lymph nodes, you ask about symptoms of pediculosis, for example. Cat scratch, as cat scratch disease may cause regional lymphadenopathy, contact with pets, travel history, consumption of unpasteurized milk if you are suspecting brucellosis, and systemic symptoms as arthralgia, weight loss, bone aches, night sweats, or the presence of one or more than one of these systemic symptoms may warrant a more, let me say, a more detailed investigations, either radiological or laboratory, as we are going to clarify later on. After history, go through examination, general look, and as what McLeod says in his book of clinical examination, the most important clinical skill is to determine whether the patient is generally ill or generally well. You have to ask your patient, is this patient looks well or ill? For example, even non-malignant causes can make your patient ill. Kawasaki disease, for example, causes unilateral cervical lymphadenopathy and the patient looks ill. Plot the weight and the height of your patient against the international widely used CDC and WHO centile curves. Lymphadenopathy, generalized lymphadenopathy can be caused by chronic granulomatous diseases and rheumatological disease and connective tissue diseases, for example, that can cause a decrease in the weight or the height of the patient, while acute infective issues will not be so rapid to make an affection on the gross parameters. Then systemic examination, chest examination for any respiratory distress that may occur secondary to mediastinal mass. This is a red alarming sign. Abdominal examination for hepatosplenomegaly. Please, if you have only one lymph node enlarged, try to examine, and you have to examine all other accessible lymph node groups. Musculoskeletal examination for arthralgia and arthritis. Skin examination for a skin rash that may occur with Kawasaki disease, with viral infection, or petechiae that indicates bone marrow depression, either to a connective tissue disease or to secondary to malignant causes. And it's very important to examine the site drained by the enlarged lymph node. As I said, if you have occipital lymphadenopathy, examine the scalp of the patient for pediculosis. If you have axillary lymphadenopathy, examine for interdigital infection in the hands, very important. If you have jugular-digastric or cervical lymphadenopathy, examine the ear of the patient, the throat, and the mouth. Then go through local node examination. And to be more systematic, while examining the enlarged node, you should ask and answer the following 4 questions. First question, is it a lymph node? From this image, from the first sight, you may think that this is an enlarged lymph node, but ultrasound revealed that this patient has a sternomastoid tumor. This is also from the first sight, you may suspect it's a malignant enlargement in the jugular-digastric or in the cervical lymph node, but it was revealed later to be a branchial cyst, one of the congenital anomalies. So not any neck mass is a lymph node. So be sure that this is a lymph node. This is going to be achieved either through clinical examination, but of course, I think you are going to need radiological assessment to know that this is a branchial cyst or sternomastoid tumor, not a lymph node. Second question, is the lymph node enlarged? This takes us to the fact that some lymph nodes are palpable, even if not enlarged, as the submandibular lymph nodes, while others are not felt except if enlarged as the supraclavicular lymph nodes, which is representing an ominous sign, enlargement of even a single supraclavicular lymph node. Axillary and cervical lymph nodes are considered to be enlarged if more than 1 centimeter. If less than, this is not an enlargement in the axillary or cervical lymph nodes. Inguinal lymph nodes are considered to be enlarged if more than 1.5 centimeter. So make sure that this is a node. 2, make sure that this is an enlarged node. Third question, what is the character of the lymph nodes? Actually, depending on the character, there are no solid rules that can drive you through examining the lymph node. The character of the enlarged lymph node, is this malignant or benign, but some clues may be helpful. Acute infective adenitis, in case of acute infective adenitis, the enlarged node or nodes will be tender, mobile with erythema and warmth-like signs of acute infection in the overlying area. Presence of fluctuation indicates abscess formation. Matted lymph node. Matted means that lymph nodes cannot be separated by one. You cannot count, this is 1, 2, 3. No. All lymph nodes are matted together, and this may indicate tuberculosis or malignancy. Malignant nodes are usually firm to hard, not tender, and fixed to the underlying structure. So if you find a hard mass in the neck that's not tender, firm or hard, and fixed to the underlying structure, please biopsy this node. Soft consistency in most of cases is more reassuring than the firm or rubbery or the hard nodes. The last question, is this a localized or generalized lymph nodes? That's why I said when you find only one node, even the cervical, please go for all other accessible lymph nodes. If 2 or more non-adherent groups is enlarged, this means generalized lymphadenopathy. Single lymph node enlargement is usually carries a benign nature, except if the supraclavicular lymph nodes. Even if only one supraclavicular lymph node is enlarged and no other lymph node enlargement, please biopsy this node. If the left supraclavicular is enlarged, this may indicate intra-abdominal tumor that is spread by lymphatics through the thoracic duct and then to the left supraclav. If the right supraclavicular nodes enlargement, this means intrathoracic lesion because the right supraclav drains the mediastinum and the upper right lung lesions. Localized lymphadenopathy is usually due to local infection. However, still there are no solid rules. Hodgkin lymphoma and the neuroblastoma may present initially with only localized lymph node enlargement. So we finished history, examination, now go through investigations. When to investigate? If infection is considered to be the cause of lymph node enlargement, depending on the history, depending on the examination, it's reasonable by many pediatricians and the hematologists to perform like a 10 to 14 days trial of antibiotic therapy, then to reassess the patient. If the node failed to return to the usual size, or if there is progressive enlargement in the nodal size, or if from the beginning you are not sure about the cause and you cannot address this case as an acute infective adenitis comfortably, please go through the following investigations. Radiological investigation, ultrasound. If you are dealing with cervical lymphadenopathy, please ask for neck ultrasound. It's a very simple, non-invasive, and reliable test. Contact the sonarist by phone contact personally to search for the following characters that can differentiate between benign node enlargement and malignant nodal enlargement. You can even ask for ultrasound now and ultrasound after 2 weeks to assess precisely the size of the nodes. Mostly benign nodes, the size will not progress, but increment in size may indicate malignant issue. The benign nodes are usually elliptical, malignant nodes are round. The borders of the benign nodes are unsharp, while malignant nodes has sharp borders. The echogenic hilum is present in the benign node while absent in the malignant nodes. In the ultrasound, in the grayscale color, you will find that benign nodes are hypoechoic while malignant nodes are hyperechoic. The intranodal reticulation and the calcifications are signs of malignant nodal enlargements. The vascular pattern is very important. In the benign nodal enlargement, there is increase in the hilar vascularity, while in the malignant nodes, mainly the vascularity is peripheral or mixed, hilar and the peripheral. But only if hilar vascularity is increased, this goes mostly with benign nodes. So please contact the sonarist while sending your patient to him and ask him to specifically search for the hilum, search for the architecture, search for the vascularity pattern and the borders and the shape of the lymph nodes. Other radiological investigations like chest X-ray may be helpful if you are suspecting TB. If there is hilar lymphadenopathy, this may go with other non-benign diagnostic differential diagnosis. I mean, if there is mediastinal lymph nodes, this carries the possibility of T-cell leukemia. So you have to go through other more precise investigations. To more precise location and extent of nodal enlargement, or if malignancy is so much suspected, you can ask for magnetic resonance imaging of the neck, chest, and abdomen. This is a radiological investigations. Laboratory investigation, you can do CBC with differential white disease count. Neutrophilia suggests acute infection in most, not all of cases. Neutropenia may be caused by specific bacterial infection like brucellosis or viral infection. Lymphocytosis may occur with viral infection or malignancy. Ask for ESR. If more than 100, this may indicate malignancy, collagen vascular diseases, or TB. If in the 30s or in the 40s, this may go with acute infective adenitis. Do C-reactive protein, procalcitonin, and the blood cultures to specify if there is infection in this patient or not. Lactate dehydrogenase still be requested by so many physicians, but it does not have so much high value in differentiating between benign and non-benign diseases. Virology panel will be helpful, either serology for Epstein-Barr, cytomegalo, or even PCR for both of them. If you are suspecting TB, you can do the TB scan test, chest X-ray, quantiferon gold test, and all these tests are available. If your patient have night sweat, night fever, weight loss, recent contact with sick patient or something, or recent travel to an area endemic in TB, you are suspecting now TB, so please do a diagnostic panel for tuberculosis. The very important question that I think most of us is asking now, when to ask for lymph node biopsy. Here are the clear indications for lymph node biopsy. These are the cases or the conditions that, if present, you should biopsy the nodes. If lymph node size is more than 2 or 2.5 centimeter. If the node increase in size over 2 weeks, you remember the 2 weeks trial that we gave? If after the 2 weeks the node is still increasing in size, no, please do the biopsy. If there is no decrease in size in 4 to 6 weeks, if the node reaches, let's say, a stationary level and then stayed in this stationary level or stationary size with follow-up up to 6 weeks, no, please take biopsy. If node does not return to baseline after 12 weeks, we say that if it's increasing in size in 2 weeks, don't wait more than 2 weeks, go for biopsy. If it reaches a certain size and remains stationary, don't wait for 12 weeks, only 6 weeks if there is a stationary level and there is no decrease. If there is a progressive decrease but not returning to baseline, you can wait for 12 weeks. But at 12 weeks, if not returning to the baseline, please go for biopsy. Abnormal chest X-ray, mediastinal mass, for example, is an ominous sign that that is a clear indication for lymph node biopsy. Presence of supraclavicular node, even if single, is indication for biopsy. Presence of systemic signs and symptoms that may suggest malignancy, as fever, of course, I mean persistent fever, weight loss, night sweat, hepatosplenomegaly, arthritis or arthralgia, petechiae, bone marrow depression. All this indicates a lymph node biopsy. So please keep this slide with you. This is an indication for lymph node biopsy. As I said, there is maybe localized lymphadenopathy and generalized lymphadenopathy. We'll start with localized lymphadenopathy, and most importantly, of course, is the cervical lymphadenopathy. Here is an algorithm that I found it to be so much conclusive about how to deal with cervical lymphadenopathy. I know that the font is so small, so I tried to divide it into separate slides. If you have patient with local cervical lymphadenopathy, please search for local infection in the ANT, skin, or the eye. If there is, please treat with the antibiotic policy that you are following. If there is no signs of acute infection, ask your patient. Does the patient have, this is not written here, does the patient have the previous red alarming sign that warrant biopsy, like the patient has systemic signs and symptoms of persistent fever, weight loss, hepatosplenomegaly, and like this? The node is hard and fixed to the underlying skin. All of this necessitates an urgent biopsy. But if not, and your patient looks systemically well, and the lymph node is less than 2 centimeters, you can review in 2 weeks. If the patient does not look well, please do not forget Kawasaki, and here are the criteria for Kawasaki: fever for at least 5 days and at least 4 of these 5 criteria for complete Kawasaki disease. If the patient is systemically well and the lymph node, if the patient is systemically well, but the lymph node is more than 2 centimeters, here we can go to the local lymph node again and examine. If there is signs of infection of acute infective adenitis, like being hot, red, tender, and like this, yes, give the antibiotic trial and follow up your patient. If there is fluctuation by clinical examination or by ultrasound, there is pus, and this needs to be referred to ENT or surgeon for evacuation. If the lymph node, as I said, does not show characters of acute infective adenitis, hard nodes, node that's fixed to the surrounding structure, node that's progressive or increasing in size, please go through the diagnostic test, either radiological or laboratory. And if there is indication for biopsy, yes, do the biopsy. This is for acute lymphadenopathy. Now, if persistent or chronic cervical lymphadenopathy more than 6 weeks, if you have a patient with chronic cervical lymphadenopathy and all of the following criteria are met, the lymph node is less than 1 centimeter, mobile, and the child looks well, this is mostly a case of chronic non-specific lymphadenitis. This is maybe from repeated antigenic stimulation, there is some lymphoid hyperplasia. This is a very common diagnosis. But if your patient has any of the lymph node is persistently enlarged more than 6 weeks, is more than 2 or 2.5 centimeters, has one of the indication of the lymph node biopsies that we said before, please go for the radiological and the laboratory workup and go through the biopsy. But actually, the real actual scenario that we face in our clinics is the gray zone. That's the patient who has persistent lymph node for more than 6 weeks. He had antibiotic trial, but the mother cannot tell if the lymph node decreased in size or not. The patient looks well, yes, but the lymph node is only 2 or 2.3 centimeter. The mother cannot tell if there is clear weight loss or not. So you are in gray zone. So when the criteria does not meet box 1 or box 2, you can do the radiological investigation and the laboratory investigation that we said before, and follow your patient at 2 weeks interval. If the lymph node decrease in size, or if there is clear diagnosis reached, like being Epstein-Barr or cytomegalovirus positive, so treat accordingly. If there is no clear diagnosis reached, lymph node did not decrease in size, there is persistent lymph node, please go to biopsy. I hope that this algorithm may simplify the issue. Here in the table of generalized lymphadenopathy, I'm not going through all the differential diagnosis because of time limitations, but I would say that the most common cause, or one of the commonest cause of persistent generalized lymphadenopathy, is non-specific reactive lymphadenitis, infection, of course, connective tissue disease like lupus, serum sickness, lymphoproliferative disorders as autoimmune lymphoproliferative disease, and this may need ALPS has a specific diagnostic criteria that must be followed before addressing the case as ALPS. Neoplastic disease at Hodgkin and non-Hodgkin lymphomas and neuroblastoma. Storage disease like Gaucher and Niemann-Pick may cause lymphadenopathy at a younger age, associated with hepatosplenomegaly, maybe mental affection and other stigma of inborn error of metabolism. Immunodeficiency states as CGD and leukocyte adhesion defect. You will have history of recurrent abscess formation. Sibling died at younger age. In leukocyte adhesion defect, you will find very severe neutrophilia in the peripheral blood differential white disease count. Other causes as Kawasaki disease not also to be missed. At the end, the take-home message is that lymphadenopathy is common and it's acceptable to be somewhat confused at first. Always keep malignancy in mind, but try not to overshoot to biopsy all the cases that you are going to face with lymphadenopathy. Be wise, but not reluctant. History and the examination are very important in dealing with cases of lymphadenopathy. Before asking for any investigations, before jumping to biopsy, please, careful history taking and careful examination, systemic and local, and answering the 4 questions that I said before is very important. Neck ultrasound is reliable, not so much expensive, and non-invasive diagnostic tools. After personal contact with the sonorist, ultrasound will be so much helpful in differentiating benign from non-benign nodes. Always memorize the biopsy indications that we said before. I think now I finished. This is the Suez Canal University and the Faculty of Medicine and the Suez Canal University Hospital. Thank you all, and I hope that it was a concise lecture that gives some information, not all the information about the lymphadenopathy. Thank you.